Hello.
Yes.
Yeah. Good afternoon to the dignitaries or the dais, scientific committee, and the audience. So today I'm going to present macular hole and its management. So coming to the macular anatomy, this is how the foveal, normal foveal look like, and this is the foveal avascular zone. And the morphology of the fovea depends upon the arrangement of the Muller cone cells and atypical Muller cone cells. So definition of the macular hole, it is a vertical full thickness neurosensory defect extending from the internal limiting membrane to the retinal pigment epithelium, affects the central vision and causes metamorphosia. So most commonly we see this in the age group of 6th and 7th decade, more common in the females than males, and it's bilateral in the 20%, and prevalence is 3.3 in 1,000 population. Coming to the etiology, most commonly, idiopathic is the most common one. Even trauma can cause macular hole, high myopias, the cystoid macular edema, and the inflammation, and vitromacular interface disorders. Coming to the pathogenesis, macular hole are caused by the tangential traction and also the anteroposterior traction of the posterior hyaloid on the parafoveal area. So this is the picture depicting the anteroposterior traction. Macular holes are noted to be complication of the posterior vitreous detachment at its earliest stage. So Gas has described the pathophysiology there was a observation of the focal shrinkage of the perifoveal cortical vitreous, and there was a tangential traction, so which lead to the foveal detachment or the break or dehiscence at the center umbo and cause a full thickness macular hole. So the newer concept by the SDOCT tomography, there is a peculiar makeup of Muller cells in the center of the fovea. So it is a Z shape. Most macular hole develop by a mechanism of central dehiscence or a centrifugal retraction. So there is a no tearing of the foveal tissue here. It's a maximum extent of the progression centrifugal retraction of the foveal photoreceptors is up to 400 microns. So gas classification by the slit lamp examination, stage 1 has 1, 2, where we see yellow reflex, and the yellow ring depends upon the lipid lipofuscin distribution. And here the vision is normal. The patients may be asymptomatic, and this is the OCT picture which depicts. Coming to the stage 2 macular hole, thickness is less than 400 microns in size. So on OCT, if you see the posterior hyaloid, it may be detached at the one edge. And the patient complains of a pincushion effect. Stage 3 macular hole is a full thickness of size of 400 microns. Nearly 100% of stage 2 will convert to stage 3. The posterior hyaloid here, it is completely detached, and we can see a operculum, but it is still attached at the optic disc. So coming to the stage 4, the posterior vitreous detachment is also seen at the optic disc. So international vitromacular traction classification on the OCT, we have vitromacular adhesion, traction, and the full thickness macular hole. In vitromacular adhesion, there is no distortion of the foveal contour. It can be a focal or a broad, depends upon the addition of whether it is 1500 microns or more. So in vitromacular traction, there is a distortion of the foveal contour. So this is the article. So coming to the diagnosis, by direct ophthalmoscopy, we can see and diagnose macular hole and slit lamp biomicroscopy examination. And if we do a Watzke-Allen test, where we can see a defect in the center of the, if we project a slit beam, we can see the defect. On OCT also, we can make out the macular hole. Differential diagnosis, a lamellar macular hole and a pseudomacular hole. In lamellar macular hole, there will be a loss of internal tissue here, inner retina, and the pseudomacular hole, there is no loss of inner retinal tissue, where we can see a epiretinal membrane with cystic spaces. Coming to the prognostic factor, it depends upon the preoperative visual acuity and the duration of the macular hole, stage of the macular hole, pre-op lens status, and the hole formation factor. Value higher than 0.5 better results, and the macular hole index more than 0.5 have a better visual outcome. Principles of surgery is we have to release the anteroposterior traction by complete vitrectomy, and release the tangential traction by removing epiretinal membrane or internal limiting membrane, and increase the elasticity of the retina, and retinal tamponade by a gas or silicon oil, and reoppose the retina. Coming to the management, stage 1 is an observation. Stage 2, 3, and 4, we have to do a surgery. So I'll show you surgical videos. So we do an anterior vitrectomy after 3 post-vascular vitrectomy.
I think we will skip the videos because we are already exceeding the time allocated for this session.
Yes, sir.
You give the conclusions.
So in this I most commonly prefer inverted ILM flap technique, do a fluid air exchange and tamponade with the gas 12 to 14% C3F8 gas. So complications we see feathery cataract, nuclear sclerotic cataract, visual field defect, raised IOP. If the gas is more, we can, like other retinal surgeries, we can see any retinal tears, segmatogenous detachments and so on. So there are other surgical options where the recurrent macular holes are there. Either we can put an autologous serum or lens capsular flap or autologous retinal transplant or human amniotic membrane. Thank you.
You have mentioned several prognostic factors. Nowadays, do you consider that they are playing significant role, or certain times even if the patient not fitting in, since we are almost achieving the success rate of 95 to 98%, will you take others which are outside this prognostic factor?
Definitely, sir, because we should not aim for the anatomical closure. We should aim for the functional closure. For functional closure, until unless there is an intact ISOS junction, then only the patient will have an improvement in the vision. Otherwise, even if the anatomically macular hole is closed, the patient will not have improvement in the vision in a chronic or large macular holes.
Yeah, means in the inverted flap technique, means previously we used to cut the duration of macular hole. Now we are not considering that. Second, size of the hole also you are saying inverted flap, but a smaller hole without flap, the visual results are better and the closure rates are equally good. So you should not go for inverted flaps in smaller holes. Third is that if hole is large, you still close it because the parafoveal area can be certain times useful to improve the central vision that may be useful for the patient. With this,